Hello and welcome to TheMedSurge. In today's episode, we're going to discuss about acute exacerbation of asthma, also known as status asthmaticus. What is asthma? Asthma is a reversible airway obstruction secondary to bronchial hyperreactivity, airway inflammation, mucus plugging, and smooth muscle hypertrophy. Acute severe asthma is an acute exacerbation of asthma that doesn't respond to the standard medical treatments like bronchodilators and steroids. The initial assessment of the severity of acute asthma is based upon the combination of clinical features, peak flow measurement, and pulse oximetry. So why do we do this initial assessment? This is to diagnose the acute asthma attack, to determine the severity of the attack and the required nature of the treatment, and also because if there's a delay in the treatment and underdosing, this can adversely affect the outcome. Clinical features. These patients will present with breathlessness, wheezing, and tachycardia. Peak flow measurement is important in recognizing the degree of severity and to check the appropriateness of the intensity of the therapy. So the patients will exhale into this device and you get a recorded value which is the peak expiratory flow rate. And the problem with asthma is that there's a presence of a reversible bronchoconstriction and it's also an obstructive type disease. So the expiration is obstructed. Pulse oximetry is used to determine the oxygenation and the need to do an arterial blood gas and monitoring of the treatment. In here, the aim of oxygen therapy is remained at 94 to 98%. In an emergency setting, there's two types of patients you might find. The ones with acute severe asthma and the ones with life-threatening asthma. So differentiating these patients is very, very important in the acute management. In acute severe asthma, these patients are so breathless and unable to complete a single sentence in one breath. Maybe they are taking some pauses in between because they are breathless. Whereas in life-threatening asthma, they are exhausted, confused, and may be in a comatose state. The respiratory rate in acute severe asthma is greater than or equal to 25 breaths per minute. And in life-threatening asthma, it's a poor, feeble respiratory effort. In acute severe asthma, their heart rate would be more than or equal to 115 per minute, but in life-threatening asthma, they will have bradycardia, hypertension, and maybe arrhythmias. In addition to that, these patients will also be cyanosed and may have a silent chest. When we're talking about the peak expiratory flow rate, it will be 33 to 50% of predicted normal or best in acute severe asthma, but in life-threatening asthma, their peak expiratory flow rate is less than 33% and also their saturation will be less than 92%. And apart from that, if we check an ABG, we can see the features that are suggestive of a very severe life-threatening attack. They are a high PaCO2 that is more than 6 kilopascals, severe hypoxemia that is partial pressure of oxygen is less than 8 kilopascals despite the treatment of oxygen, and a low or falling arterial pH. So who are the patients that are at risk of developing this fatal asthma? Previous near fatal asthma, previous admission with asthma, especially within the past 12 months, requires more than 3 classes of asthma medication, heavy use of short-acting beta agonists, non-adherent with regular asthma therapy, failure to attend for regular follow-up after an exacerbation, using or recently stopped oral steroids, psychological issues, drug or alcohol abuse, obesity, and finally, learning difficulties. Based on these severities, we can manage the patient. Management. In the immediate non-pharmacological management, admit the patient to an acute site bed and assess the ABC, that is airway, breathing, and circulation. Connect them to a monitor, measure their saturation, and administer high-flow oxygen via a face mask or non-rebreathing mask with a reservoir bag, and our target SpO2 is 94 to 98%. In addition to that, check their peak expiratory flow rate and oxygen saturation. In pharmacological management, so the problems in asthma is they have a reversible bronchoconstriction and airway inflammation. The first line drug is bronchodilators. In here, a short-acting beta-2 agonist like salbutamol is used. 5 mg salbutamol nebulization or terbutaline 10 mg given in every 15 to 30 minutes and is given 3 times as back-to-back nebulization. Oxygen-driven nebulizers are preferred to minimize the risk of oxygen desaturation while using these air-driven compressors. If this is a patient with severe life-threatening asthma, you may have to add ipratropium bromide 0.5 mg and nebulize every 6 hours. This helps for a faster recovery and shortens the hospital stay. Then you monitor the response, check the oxygen saturation, heart rate, respiratory rate, and peak expiratory flow rate. To reduce the inflammation, we need to add a corticosteroid. So IV hydrocortisone 100 mg is administered and continued 6 hourly up to 24 hours. Early use of steroids in acute asthma reduces mortality, relapses, subsequent hospital admission, and requirement for a beta-2 agonist therapy. And then the patient should be started on an oral prednisolone 40 mg stat for 10 to 14 days. If the patient is still not responding, do an ABG and check if there is any life-threatening features that are PaO2 less than 8 kilopascal despite oxygenation and the presence of acidosis. Next up in the management is IV magnesium sulfate 1.2 to 2 grams in 50 milliliters normal saline as an infusion over 20 minutes. Magnesium sulfate has bronchodilator effects and it reduces hospital admissions in adults with acute severe asthma who have little or no response to standard treatment. But make sure to be very vigilant because repeated doses of magnesium sulfate can cause hypermagnesemia, which may present with muscle weakness and respiratory failure. Last option is IV salbutamol, which is given with cardiac monitoring. A chest X-ray is not routinely recommended but is urgently needed in a suspected pneumomediastinum, a pneumothorax, life-threatening asthma, initial treatment failure, and require for ventilation. Antibiotics are not indicated. As a supportive therapy, correct the dehydration, correct if they have any electrolyte imbalance, and manage hypokalemia because it could be caused by the beta-2 agonists. By this time, your patient might have responded well to this treatment. So their peak expiratory flow rate may have gone beyond 75% and they could be hemodynamically stable. Or they may have not responded to this treatment at all. For those who responded, they can be discharged and they are given a metered dose inhaler and an oral prednisolone for 10 to 14 days, which is tapered and stopped later. But if this patient keeps deteriorating and unresponsive to treatment and hemodynamically unstable, has hypoxia, carbon dioxide retention, feeble respiratory effort, respiratory arrest, silent chest, and altered level of consciousness, refer these patients to an intensive care unit or a high dependency unit. So the criteria to refer these patients to ICU or an HDU is deteriorating peak expiratory flow, persisting or worsening hypoxia, hypercapnia, ABG analysis showing a falling pH or rising H+ concentration, exhaustion and feeble respiration, drowsiness, confusion and altered conscious state, respiratory arrest. If these patients has any of the following, they must be admitted to the ICU and must have a continuous nebulization with intravenous steroids and intravenous salbutamol. Ventilatory support is also required. Not all patients who are admitted to the ICU needs ventilation, and whether they need a ventilation or not, that decision is taken by either an anesthetist or an intensivist. I hope you guys learned something today, and if you did, please hit the like button and comment your ideas, and subscribe to my channel for more content like this. And as always, thank you for watching. I'll see you on the next video.